Gary, and I will introduce and facilitate today's webinar. And we are very happy today to have all of you joining us to discuss strategies to increase male engagement in eMTCT of HIV and syphilis. We are pleased to host this webinar from the World Health Organization, the Department of Health and Research, and in our department, this includes the special program of research, development, and research training in human reproduction. And our role as a department is to provide leadership in sexual reproductive health and rights research, to develop normative guidelines and research capacity building. As part of our key areas of work in the department is strengthening linkages between SRH and HIV. And this includes prevention of HIV and syphilis transmission. And thus the importance of this webinar for us. So if we move on to the next slide, today's event is the first in a series of webinar discussions where we hope to discuss important issues in SRH-HIV linkages. And on the next slide, you'll see we've highlighted that we really value your feedback, and it will help us really critically shape what this webinar series can look like going forward. And we welcome everyone to share your ideas for future topics of webinars related to SRH-HIV linkages. And this can be done in the question box in the control panel on the right side of your screen. We have asked our panelists to share their insights and experiences on integrating men and boys in eMTCT initiatives in diverse settings. And we hope that the panelists will both highlight their challenges and opportunities that they have experienced. During the presentation, please feel free to type any question or comment that you may have in the question box of the control panel, and we'll be able to answer them at the end. So moving on to the next slide is the issue of the importance of men in global SRHR agenda cannot really be emphasized. Certainly, global attention paid to women and girls is critical for overall success of SRHR agenda. However, that said, to really achieve the ambitious goals in the various global, regional, and national initiatives, we really need to also engage men and boys where appropriate. This is particularly true for the Sustainable Development Goals on health and gender equity. And today we have 6 panelists, which if you can move on to the next slide. We have 6 panelists who will seek to unpack how we can achieve this. I will not go into what each panelist will present as it is outlined on the slide that you can see. The panelists come from various backgrounds. We have panelists from WHO. We have panelists who are engaged in a lot of activities on male engagement. And we have panelists with a lot of experience in program implementation. And we really look forward to hearing from them and also to your questions and participation in this webinar. So finally, welcome everyone. And now I'll hand over to Manjula Narismahan for a brief introduction to frame this webinar in the context of SRH-HIV linkages. So Manjula, welcome.
Hello everybody. Good afternoon from Geneva, and thanks very much for participating in this webinar. My role here is really to highlight the importance of linkages and integration of sexual and reproductive health and rights with HIV intervention. And I just wanted to, if we get to the next slide, please. And this area of work really started with the Glion call to action in 2004 that catalyzed the linkages between the family planning and HIV fields. And since then, the field has really progressed considerably. And if we go to the next slide, please. What I've tried to put here is resources. No, the slide before, please. Yes, resources that can be found, as we will not have time during the webinar to delve in greater detail. So the Department of Reproductive Health and Research, SRHR, co-convenes an interagency working group on SRH and HIV linkages, and many of the resources from over a decade can be found on the first web link that you can see, as well as other sites such as the Integra Initiative and the eMTCT website can provide further details. But as you can see, this is an area that has developed considerably to try and reduce silos between reproductive health, sexual health, HIV, STIs, and rights. Next slide, please. And the activities are really aimed to foster dialogue among those who still work in silos, not only at policy and health systems levels, but service delivery and funding, which often still is quite separate even today. I wanted to speak about, just very briefly, about the high-level meeting on ending AIDS, which is taking place this week in New York. And member states have agreed to reach ambitious new targets by 2020 and pledging the end of the AIDS epidemic as a public health threat by 2030. So the UNAIDS fast-track approach to this is considerably reducing the number of people newly infected with HIV, reducing the number of people dying with AIDS-related illnesses, and eliminating HIV-related discrimination. And really, this can only be achieved if we have a multi-sectoral collaboration and strengthening the linkages between the HIV, STI, and sexual and reproductive health. Next slide, please. eMTCT is one area that has really demonstrated success in the integration for the health of the child and of the mother. But initially, PMTCT was only focused on providing HIV treatment and care, known as prong 3 and 4, and primary prevention and preventing unintended pregnancy among women living with HIV, known as prongs 1 and 2, were often left off the agenda. So these successes has really happened because there has been political commitment, there's been funding and specific goals set, and the successes has been grounded in providing comprehensive, a holistic approach to sexual and reproductive health and rights. In 2000, there was only about 1% of women living with HIV receiving antiretroviral therapy, and by 2014, this figure was up by 75%. So this is really an area where people have worked together to make the agenda move forward. Next slide, please. And now what we're doing is linking not only perinatal transmission of HIV to the perinatal transmission of syphilis, but we're also linking it to viral hepatitis. And last month, the World Health Assembly approved 3 global health sector strategies linking HIV, STIs, and Hep B. And one of the common priorities here across the 3 strategies is the triple elimination target of eMTCT of HIV, syphilis, and Hep B. And this really promises to be an important step forward to fast-tracking the end of the AIDS epidemic. Next slide, please. So as my last slide, I just wanted to highlight 2 important things. One is, in this week, again, another milestone has been reached, and WHO has validated the elimination of HIV and syphilis in Thailand, Belarus, Armenia, and the Republic of Moldova. And the WHO Assistant Director General, Ren Mingui, has stressed that this success is testament to the importance of integration of maternal and child health programs with sexual and reproductive health and HIV services. So the importance of integration, the importance of linking, the importance of working multisectorally is becoming more and more evident. And lastly, and most importantly, I really want to emphasize that eMTCT has been and is about women living with HIV and preventing HIV transmission to the infant. Historically, many PMTCT programs have organized their services as if the potential clients were free to act independently. Thus, most awareness and implementation efforts relating to family planning or HIV prevention and care have been directed primarily at women, disregarding perhaps the cultural, the gender norms, the violence that impact women's decision-making regarding their health, their well-being, their rights. And issues such as pregnancy and health are really deeply influenced by their partners and their communities and social norms and beliefs. And I think we'll get more into that later on in the presentations. But it is really important to highlight that women are often unable to negotiate safer sex or safe sexual practices such as condom or contraceptive use that can lead to HIV infection, STIs, or an unplanned pregnancy. And the fear of rejection, stigmatization, and violence is a reality for many women living with HIV. And this was shown in a global community survey that was conducted by and for women living with HIV in 2014. Even the language of mother-to-child transmission rather than parent-to-child transmission and the language of eMTCT really targets women. So the involvement of male partners may play a role, for instance, to facilitate couple communication related to sexuality, but must never be seen as coerced or a given. And the goal of this webinar is therefore to discuss what strategies to increase male engagement in eMTCT of HIV and syphilis might or might not be desirable. The well-being of women living with HIV and their children really remains central to this discussion. Thank you very much.
Thank you all. This is Gary Barker. I'll talk now about what we know somewhat around engaging men, what we've learned from the process, and some of the motivation for why we're doing this. Let's move to the next slide, please. Thanks. I think it's important to start off that there's certainly been lots of small-scale approaches around engaging men in sexual and reproductive health and rights, and including in the HIV field. But really where I see the field is needing to move next is how do we go from smaller scale approaches, mostly led by NGOs, important as they have been, to really taking this up to a larger scale and embedding it in the health sector, as I think a lot of our success stories with women's health and particularly around maternal and child health have been. So first, just a little bit of the why on this. We certainly know that, as Manjula just said, we know that women's decisions around family planning use, contraceptive use, and in terms of protecting themselves from HIV and other STIs are heavily affected by men's decisions, particularly power dynamics, men's use of violence, and other not so subtle and subtle social pressures in terms of men's preferences often driving women's decision-making power. So certainly as a first issue we need to talk about that, and always to keep in mind issues of power and inequality as we engage in this work. And I think there's also a major fairness issue. We know that men's family planning use is only about 25% of total contraceptive use in the world. That is little change since the 1980s. Certainly we have an issue of investing more in male methods, but I think it is important to talk about the need for an equity issue there of men being a greater part of both supporting female partners' use but also their own use of contraceptives. And I think it's also interesting to talk about our limited success of clinic-based efforts to engage men. We know that globally men's STI and HIV testing is much lower than women's in most settings, in many cases because women's access to HIV testing has been via antenatal or prenatal visits. So one of the things that we at Promundo have been looking at in the last couple of years is whether the prenatal visit can also be a pathway, or whether the primary health sector in general can be a pathway for engaging men and perhaps going to scale. Next slide, please. One of the things that we see is that from household data that we've carried out and others is that a fairly high percentage of men accompany a partner to a prenatal visit. These are numbers from our International Men and Gender Equality Survey from a few of the countries. They're men's reports of going to an antenatal visit compared to women's reports of whether a male partner accompanied them. Men report higher rates, which is always a bit curious. They're reporting higher rates than women are. But even numbers from women are suggestive that a lot of men are accompanying a partner for at least one visit. Now, many times they're outside the clinic, they may have dropped her off. Sometimes they get into the waiting room, seldom are they invited into the consultation room. We certainly want to do that, as Manjula noted, in ways that are non-coerced and that the choice is always the woman's. But it does tell us that there may be a missed opportunity for us to engage men in large ways. And in fact, in the context of Brazil, we know from data there that in fact a men's visit to a prenatal, to accompanying a partner to a prenatal visit is the most common reason that men go to a primary health care clinic. Next slide, please. So based on these numbers from in Rwanda and Brazil in particular, we've been testing approaches to figure out ways to increase men's engagement, both around HIV testing and HIV and access to treatment, as well as figuring out ways to engage men in other things, GBV prevention, their support for sexual and reproductive health in general, and to engage them as partners in maternal and child health. In the case of Brazil, this has been a collaboration with the men's health sector created at the Ministry of Health in 2008, which has recently created a men's prenatal health visit protocol as a way both to engage men as partners in maternal and child health, to increase HIV and syphilis testing, but also to look at it as a pathway to men's own health needs. Most of that's focused on health worker training, and I'll talk just briefly about some of the results from that. And then secondarily, I'll talk very briefly about a randomized controlled trial that we're doing with a parent training approach that is also recruiting of pregnant couples using the clinic as the point of entry. It's a 16-week parent training module with activities in sexual and reproductive health, gender-based violence, and maternal and child health. Next, please. First, I'll share a little bit of data from, this is from Brazil's approach. So far, there's been a soft rollout, I think we can say, across the country of an approach to engage men in prenatal visits. When the woman comes in, there's a protocol that says she is invited to bring the partner in. The first visit is always with her alone. She is invited to include him later in that same consultation or for the next time. And then this is data based on 6,000 interviews from across the country of the soft rollout. This first slide, and I apologize that it's in Portuguese, but basically that men were asked, that is at 6,000 interviews with men. During the consultation, did the health professional talk to you? About 57% of men said that the health professional talked only to the woman or mostly to the mother, and about 42% said that he talked to both of them equally. So this does suggest that more health professionals are talking to men. We don't suggest that it needs to be entirely equal in that talk. It is her body, certainly her needs that need to be put there first. This does suggest there's some work that still needs to be done perhaps for women to see for health providers to see men as an important partner there, but I think it is an interesting indicator. Next, please. Of the men who go to a prenatal visit together with their partner, 14% of the men are going for some follow-up. That is, once he comes into that consultation, he's invited to come back for another session just for himself. And what we see in the slide here, and most of those, although in Portuguese I think you can understand, says what he came back for in terms of exams. So the largest one is simply blood typing, and the second largest one, quite important, is HIV testing. So a fairly large number of the 14% of men who are going back for their own consultation are going for HIV testing. Later on you'll see hepatitis B and C and also syphilis testing. So this is proving to be an important port of entry to engaging men around HIV and other STI testing. Interestingly, in a couple of municipalities where there's been more effort to make men and women aware of this prenatal visit for men, we're seeing that up to 60% of men are going to a prenatal follow-up visit just for himself. We hope to have more data later on. Next, please. I'll shift quickly into what we're learning from Rwanda. In the case of Rwanda, we're carrying out a randomized controlled trial. It's a 15-week parent training. 10 weeks of those are with fathers alone. 5 weeks include the couple. With group education activities around maternal and child health, sexual and reproductive health, gender-based violence, and violence prevention, both men's violence against women and parental violence against children. And it's based on a manual that we've developed called Program P that's now being used in about 15 different countries. Next, please. Here's the design. It's a two-armed, multi-site, randomized controlled trial. We've got the first round of inline data that's 4 months post-intervention, and we will have follow-up data that's 16 months post-intervention coming out of the next months. We will be publishing, we hope, by the end of the year. We're currently writing up the data, but I've got some preliminary data to share with you. But what we feel quite confident about is we've had extremely high response rates. Rwanda is quite a unique setting in terms of getting men to come to more than 90% of the sessions, and we've got very high response rate in terms of being able to follow up with the pre and the post. So let me share then some very quick results because I know I've got about a minute left. Next slide, please. Here's some of the data that we have. Compared to the control group, men in the intervention group were more than 2 times as likely to use family planning with women. Reported in the results, they were 2 times more likely to accompany a partner to 2 or more antenatal visits. And interestingly, women's reports of violence show that the women in the control group were about 2.5 times more likely to have experienced physical or sexual violence in the last 3 months compared to men in the intervention group. We think it's also important to see some of the data around men's increased participation in child care and household tasks, and that they were more likely to hold equitable attitudes. We think these are quite important to say it's not only about the direct health outcomes, but can we also shift power imbalances in the household? Can we also get men more involved in the long term in terms of the daily care of children? So we're quite excited about this. Results coming out are being shared with the Ministry of Health in Rwanda, and we're discussing possibilities of going to scale. Just one final note on the Brazil example. One of the things we're doing next, given Brazil's vast size, is to do online health professional training using an online module. We had hoped in a first year to have about 500 total participate in that training. So far in the first month we had more than 600 participate, and the Ministry of Health anticipates about 5,000 health professionals participating in that over the course of the year. So we're encouraged by these results. I think the big point is how do we go to scale? And how do we go to scale with an approach that takes into account women's autonomy, power issues, and a do no harm approach, while also listening to women, listening to men, and finding benefits that are good for women first and foremost, children as well, and men themselves. Thank you.
Hi, thank you for the opportunity to participate. I am going to talk about some of the best practices, next slide please, in relation to involving men in PMTCT, and including some country level examples, a focus on the health system, policy, and also speak briefly on some unintended consequences. Next slide, thank you. Manjula talked about the 4 prongs to PMTCT at the beginning of the webinar, and I'd just like to emphasize how important men's roles are throughout each of those prongs, and you see them in front of you there. The recent progress report that UNAIDS has on the PMTCT global plan highlights particular progress, as Manjula mentioned, in relation to prong 3 on the prevention of new infections amongst children. But whilst there's been great benefits in terms of strengthening integration with the focus on primary prevention through prongs 1 and 2, actually in many respects that's where we need to do a lot more. You know, the things that happen particularly to women outside the health system, the pieces around how do we prevent infections in the first place through prong 1, and how do we prevent unintended pregnancies, and women's needs women's unmet need for family planning remain critical barriers as identified by the progress report. So really, if we want to move this agenda forward at all levels across all prongs, it's really critical that we involve men. Next slide. I wanted to also say very briefly, and Gary has given a good kind of outline of this, what do we mean when we say male involvement within the context of PMTCT? Typically, male involvement programs will aim to challenge harmful male gender norms and promote equitable roles. They'll aim to improve communication between partners and help men in particular with women to think about the lexicon that they can use to ensure that they can both be involved in such as family planning and HIV programs. We often find that men are ignorant or misinformed in relation to these issues, so programs seek to increase their knowledge, acceptance, support and use of services for their own benefits and for the benefits of women and children. And we've seen, through evidence that these interventions, when done well, typically and importantly in relation to PMTCT, will lead to women's uptake of HIV services. They have been shown, and this was also highlighted as a particular challenge within the progress report I mentioned, to improve retention and adherence amongst women, to support improved infant feeding, ultimately therefore to reduce vertical transmission, and importantly the contextual piece that Gary mentioned and reflected in Manjula's opening comments around these programs are also trying to shape and change relationships and ensure that these relationships are more equitable. And if you go to the next slide, I wanted to emphasize that it's particularly important, Manjula talked about coercion, and those of us who work in this field believe strongly that programs should be gender transformative, and that they need to acknowledge they need to not just acknowledge the gender drivers, but also challenge the power structures and inequalities that both Gary and Manjula talked so eloquently about. And as it said in the previous slide, that would necessitate therefore that it's not just enough for a man to be paying their wife bus fare to come to the clinic. It really is about challenging the structures in which decisions and women's autonomy and ability to access the services and men's take place. Next slide, please. We really have limited overall kind of rigorous country examples, and that's why the work that Promundo is doing and others is so critical in terms of building the evidence base around this work. Through my own experiences and also in particular through my PhD work within Malawi, there's a clustering of what would be regarded as good practice examples emerging from a number of countries within the sub-Saharan Africa. Those will include, for example, couples HIV counselling and testing, national strategies on those, community mobilization targeting local authorities and healthcare workers, capacity building of healthcare staff to serve couples, public awareness campaigns using mass media on couple testing, including indicators for couple testing within the work that's undertaken at a national level, weekend HIV counselling sessions and testing sessions for men and their partners, being innovative in terms of the ways that we reach out to men. So for example, invitation letters have often been used within the PMTCT setting. Gary talked about the work that they're doing through Programme P in terms of working with men and their partners, and we've seen the effectiveness of groups in relation to PMTCT work. Within Malawi, there were efforts to support women who had brought their partners to be able to be prioritized, although I know that this often can also have unintended consequences, which is why I think it's really important that we think about gender transformative programming. And within Zimbabwe, the option B plus model that I'm sure you're all aware of, adding to that strategy which focuses on universal treatment to all expectant mothers regardless of their CD4 count, the testing of the male partner and the provision of treatment for the men. So there is an emerging basis from which we can work with a number of countries around how do we do this work of engaging men for PMTCT. Next slide, please. In the spirit of thinking about integration and the limits of the clinic approaches, I think we also need to think about engaging men within the health system as a whole, and Gary also talked about this, but that includes, for example, what's the package of services that are available for men. So there's often an insufficient target on men and couples within HIV/AIDS and sexual reproductive health services within a clinic setting. What about the clinical environment, the setup, the information that's available? Is it something that would be appealing to men? The opening times, we know that men often work during the day, and many in my own research point to the fact that the clinics tend to be closed when they would want to access them. Concerns around confidentiality and privacy, not wanting to see others, worried about the results being shared. And then provider attitudes and skills. Do providers have the skills to deal with men? What is their attitudes in terms of working with men? And there's a quote here from a health provider in Malawi, pointing to the fact that the clinic space is often not a great space for women, but if we want women and men to be coming to the clinic together, we really need to be working in particular, in addition to what we need to keep improving for women, thinking about how we improve men's access to sexual reproductive health services. Next slide, please. I also want to add the importance of the policy level, and right at the start a number of global frameworks were mentioned. And for me a best practice is also thinking about the role that policy plays as normative guidance at a global level and also at a national level. And if you look at two of the key global documents around this area, the WHO eMTCT strategic vision and the global plan towards elimination of new HIV infections, there is barely reference to the importance of male involvement. There is recognition of gender equality as a kind of foundational condition for ensuring effective PMTCT and eMTCT, but at a global level we aren't reflecting the importance of this work within our guidance documents and in our normative frameworks, and I think it's critical that we think about that, not least because that then drives the priorities at the country level. And I've seen through my own work in Malawi that, such as the National Strategic Plan on HIV/AIDS, there are no specific strategic targets around men and PMTCT, and we know that what gets collected often gets funded. And when I asked the Ministry of Health, why is it that there is no particular focus, in terms of data collection around this particular issue, the response was, as you can see below, that their priority, importantly, was for women and children. But I think saying things like that, men are a luxury, I think ignores the contextual pieces that Manjula and Gary both spoke about around the fact that we can't deal with this issue solely as a service provision issue. We've seen, as I said right at the start, the lack of success, in particular around prong 1 and prong 2 and primary prevention, and therefore we need to be thinking much more holistically, and our policy context both nationally and globally needs to reflect that work. Next slide, please. I wanted to also highlight that there is some building blocks around evidence and programmatic understanding of this work. WHO has a publication which I think is available for those participating in this webinar on male involvement in PMTCT, which highlights benefits, barriers, some of the evidence to this work. There are a number of studies, 2 of which I've highlighted on this slide, but I think there is very little overall rigorous evidence around this work. That's why it's so important what the Promundo and others are doing to increase our understanding of what works in relation to this and how we scale it up, as Gary said. But we do need further research, we do need to strengthen the implementation science, and I would argue we do need guidance for countries and implementers about how to do this, and we need to learn the lessons from these studies and the prior work that WHO has done. So really a call for building on our lessons learned and thinking about guidance for the future. Next slide, please. One of the constructive things for me through my work in Malawi was not just thinking about why is it necessary to involve men in PMTCT, but what happens if they're not involved? What are some of the unintended consequences? And I say this within a framework of, as I mentioned at the start, recognizing that this work must be done in a way that recognizes the power dynamics and ensures that it's gender transformative and tries to challenge some of the existing hierarchies in which this work takes place. But I saw, as a result of men not being involved in PMTCT, women unable to negotiate safe sex, and therefore mitigating against prong 1 in terms of preventing new infections. Also women being unable to negotiate condom use, and then an increase in unintended pregnancy because their partner wasn't supportive, as Gary referred to, in terms of access to family planning, and the need therefore really for men and women to be engaged together. The fact that women are often the ones within the relationship that find out their status, and then the negotiation that the woman has to do with the partner around disclosure, often leading to violence against women, as we know so well from research, blaming women for the infection. And I think importantly, it's also a huge missed opportunity for men. I mean, to engage them. Gary talked about the need for us to increase men's FP uptake, which I would wholly support. But I also think evidence is increasingly showing that proportionally men are less likely to test for HIV, are starting late on antiretroviral treatment, are often more likely to die on ART. So I think it's really important as we think about working with men and women together, how do we ensure to engage them, and how do we address misinformation, stigma and fear as a result. If you just move on, I think I'm running out of time. And move to the next slide. So in conclusion, what are some of the actions that I would suggest? So we need to shift our conceptual understanding of this issue, that men do have a key role to play in PMTCT. We need to think about the programs and be more sophisticated in the work that we do, both theoretically and also in terms of scaling up, and how do we strengthen implementation science. We need to continue to build the evidence base and need greater research, address the policy gaps as I mentioned, address the structural issues, and really play to the fact that we do have significant low-hanging fruit, men's strong interest in this issue, couple and family-centered approaches, fatherhood approaches, and that actually bringing men to the table in the ways that we are suggesting really support the integration of family planning, sexual reproductive health and HIV/AIDS, which we know is so central to the success of our work. Thank you.
Okay. Thank you for having me. It's a pleasure to be part of this innovative webinar. I'll discuss briefly the morbidity associated with mother-to-child transmission of HIV and syphilis, as well as the concept of male engagement at the antenatal care and patient prevention levels. And we'll also talk about the process of evaluating countries' partner services programs during the validation process for elimination of mother-to-child transmission. Next slide. The most recent estimates still show the burden of mother-to-child transmission. In 2013, there were 240,000 mother-to-child transmissions of HIV. As we know, approximately a half of these infants will die at 24 months if they're not diagnosed and treated with antiretroviral therapy. And we also know that the prevention relies on maternal diagnosis and antiretroviral therapy as well. In 2012, our most recent estimates of adverse pregnancy outcomes associated with maternal syphilis indicate that there were 350,000, and approximately half of these infants born to mothers with untreated syphilis will occur as stillbirths and neonatal death. The prevention for mothers diagnosed with syphilis is penicillin. The majority of the cases, as well as the large burden of morbidity, still lies in sub-Saharan Africa, as well as South America and some parts of Southeast Asia. Next slide. For HIV/S, for syphilis, we need to rely heavily on the diagnosis of HIV and syphilis in the mother, but it also relies on their partners being cared for at or near the same time in order to prevent reinfection for syphilis, as well as to prevent primary infection in the pregnant woman were the man to be positive and the woman to be negative. So I'll talk about that in a minute. The process for countries that apply for validation of elimination of mother-to-child transmission of HIV and syphilis does include an objective evaluation of male engagement specifically related to partner notification and contact to an infected person, and also treatment of these partners for HIV and syphilis. And this component of the prevention program, as evaluated by the WHO and the regional validation teams, is included in the process for countries that are applying for validation. However, male partner notification and treatment after diagnosis in the pregnant woman does not always prevent infection in the already infected woman. And so what I would like to demonstrate through discussion of current practices is that what our current services offer may not actually be preventing mother-to-child transmission. It may take an expansion of male engagement in order to prevent cases that are otherwise missed. Next slide. It's nice to hear that we have some overlapping studies in that it is evident that there's not a lot of data on male engagement in the PMTCT and eMTCT processes. So I have presented 4 studies here, and some of these have been mentioned previously, which is helpful, regarding the fact that there are some successful programs that have included couple counseling and community-based campaigns, which have resulted in increases in male partner testing for HIV, as well as male engagement in antenatal care. There are several other studies that I could have chosen, but I felt these were important in that they were country-based, including Rwanda, Mozambique, as well as Uganda, and there also includes a systematic review that shows that male partner HIV testing can be improved by couples-based testing. And couples-based testing is a special topic I would like to mention a bit further. Next slide. Now these are some very simple cartoons of the scenarios that women may encounter when they go in for an antenatal care visit, with or without their partner. I would like to draw your attention first to the second scenario, where a woman goes in and is diagnosed with HIV or syphilis, and she's told that she has HIV or syphilis, and then it's up to her to go home and tell her partner, who turns out is also HIV or syphilis positive. Now that is our current practice, and that's the minimum that we expect from countries that are applying for validation. But the question is this true prevention? Because both of the partners are already positive, so at best you can put the male partner on treatment as a personal health benefit, but the prevention to the mother that's a missed opportunity already. And so the mother gets put on treatment, and hopefully we can keep her from having an infected infant. Now the tragedy is when we see cases of pregnant women, which I'll draw your attention now to the first scenario, a pregnant woman who goes to antenatal care and learns that happily she is HIV and or syphilis negative. However, she has acquired only pregnancy through sexual activity. However, there's still the opportunity to acquire HIV because her partner, unknown to her and likely unknown to the partner, is HIV or syphilis positive. And so what can occur is this woman, thinking that she is negative for HIV and syphilis, and presuming that her partner is also negative, continues to be engaged in sexual activity, but later acquires syphilis or HIV in pregnancy. And we know clinically that this is much more harmful than having acquired HIV at an earlier stage, or syphilis particularly at an earlier stage, because the latency period of syphilis oftentimes prevents women from having adverse outcomes. However, an early stage of syphilis during pregnancy oftentimes leads to stillbirth or neonatal death if undiagnosed. So I'd like to advance to the next slide. So this is the opportunity to engage men at an earlier stage during antenatal care has many benefits. And outside of the obvious benefit that we just discussed of possibly preventing a negative woman from acquiring HIV from a positive partner or syphilis from a positive partner, there are additional benefits that have already been mentioned. We know that from the studies that I had shown earlier that there is an increase in male partner testing. We also know that the opportunity for prevention counseling exists when you identify discordant couples, as well as the opportunity to have more of a simultaneous disclosure between partners that is not dependent on the woman, partner referral for treatment, and then, of course, HIV prevention if there is a discordant partnership, meaning one person has HIV or syphilis and the other one does not. There are some secondary benefits, and these have also been mentioned, and I wanted just to stress the reduced burden of disclosure on women to male partners were we to consider expanding male engagement to include attendance at antenatal screening visits, preferably the first antenatal visit where screening of both the pregnant woman and the male could be done at the same time. And many of these studies listed below have already been mentioned, so I'll go on to the next slide and talk a little bit about country experience. Cuba, as you know, was the first country to validate elimination of mother-to-child transmission, and this was in 2005. Cuba has similar characteristics to some of the recently validated countries in that they have a universal health care coverage system that ensures HIV and STD testing, STI testing is available at no charge. And also in Cuba, the STI contact tracing or partner notification, male partner notification is offered routinely. If women choose to have this, women can refuse these partner notification services, but then again, the burden is up to them to notify their partners. Free testing and treatment is available to partners as well. And in the case of Cuba, we know that there were very few HIV and syphilis transmissions. However, we know that there were, among the countries that were validated just last week, if you could advance to the next slide, for Thailand, as well as the countries in the Euro region, Belarus and Armenia, these countries, although they had very few HIV transmissions, each of these countries experienced the scenario that I mentioned before, which was when a woman is diagnosed as HIV or syphilis negative. However, she then acquires these one or both of these infections at a later time in pregnancy and is undiagnosed. And undiagnosed women become untreated women, and thus the risk of HIV or syphilis transmission is very great. And oftentimes, at least for syphilis, these outcomes are fatal for the infant. Now, in the case of Thailand, there is also similarity with the other countries in that they have a very strong HIV partner testing and treatment package as part of their universal health care coverage and as part of their eMTCT program. However, some countries, like Thailand, have not expanded their partner services programs to include partners of women diagnosed with syphilis. And so oftentimes when we speak of these eMTCT programs, they frequently default to the HIV program. But we know that there are more cases of congenital syphilis born each year or born as stillbirth than HIV. And as a part of this integrated elimination of mother-to-child transmission campaign and validation process, we bring attention to the fact that syphilis services need to be improved, as is the case of Thailand, where including partner testing for syphilis was a recommendation to include in their universal health care services. Next slide. I'd like to conclude by summarizing some of the things that I've discussed, specifically pertaining to male engagement and the support for partner testing and treatment that should be connected with antenatal care, but also to propose that we should include men early on in the antenatal care program, specifically at the first visit, such that simultaneous testing or couples testing can be undertaken and women are not faced with the burden of telling their partner of their serostatus, and also men can be engaged quicker in care to potentially prevent women from becoming infected if they are, in fact, HIV or syphilis negative at that first visit.
the validation process for countries that have eliminated mother-to-child transmission will continue to include coverage and evaluation of coverage, of treatment coverage for male partners, and also partner notification. And we also in countries that are developing eMTCT, or elimination of mother-to-child transmission strategies, to include partner services and male partner engagement in their programming, including at a minimum of partner testing and partner treatment. Next slide. I'd like to acknowledge the people on the slide, and at this time I'd like to pass the presentation over to Dr. Sonia Caffey. At the bottom of the slide there are also some helpful websites for tools related to validation of elimination to mother-child transmission. Thank you.
Good morning and good afternoon for some. Good morning from Washington. Thank you for having me. It's a pleasure to be part of this esteemed panel and activity. In my speaking time, I will present some highlights of the experience in the Americas related to male involvement in eMTCT of HIV and syphilis. Next slide, please. I will basically try to illustrate 2 points. One is how we have promoted SPAHO with the other partners we are working with on eMTCT in our region, how we have promoted male engagement in eMTCT, and then I will also briefly elaborate on some country experiences. Next slide, please. The reason why in our region we emphasized and we continue to emphasize the engagement of men in eMTCT is already basically addressed by several of the speakers. One is obviously the biological imperative that Melanie spoke about, because when we are engaging in eMTCT, which is elimination, we are setting very high targets. And those high targets require that basically every case counts against achieving the eMTCT targets, and so we were exploring what the missed opportunities are that we can breach to make sure that countries do reach the high targets and the high impact levels that eMTCT requires. And so we recognize that the risk of reinfection with syphilis during pregnancy is one of the barriers. We actually, I had the privilege to be part of a team, a group that did a modeling exercise in Brazil, and it illustrated the significant impact of reinfection with syphilis during pregnancy, and that Brazil, in spite of a very significant and very intense program, was at danger of not achieving the eMTCT targets if reinfection was not reduced. And Melanie also mentioned the risk of that pregnant women in a zero discordant relationship might have a higher risk to acquire HIV, and also during pregnancy, and also a higher risk of transmitting HIV to their children. And so we really saw, apart from the biological imperative, also what several speakers already mentioned, to reduce the risk of violence and also to ensure that men are part of the process to protect the health of their infant before, during, and after pregnancy to achieve eMTCT. Next slide, please. And so what did we do in our region? Basically, for the promotion of male involvement, we ensured that we included that in our technical guidance. You see a picture of one of the main technical documents that we developed, which is a field guide for countries that lays out the recommendations for country programs to achieve eMTCT. And some, I just mentioned some of the recommendations that are in the field guide to involve the male partner in risk reduction counseling in ANC settings, engaging men as partners in the establishment of a zero-tolerance environment for intimate partner violence, active promotion of HIV and syphilis testing, and of course treatment, and as I mentioned, protection of the health of the unborn child. What we are recommending in the field guide is basically starting from preconception health, and we know that not every opportunity will apply to every context, but we are just highlighting what the opportunities are to engage men. From preconception health, where we encouraging that men and women, that the partners assess and verify their HIV and syphilis status even before getting pregnant, during pregnancy, but definitely also after delivery, and certainly that applies to a context of breastfeeding, to ensure that they have all the information and continue to be conscious of the risks of HIV and syphilis infection in the the male and female partners for the health of the baby. So that's one approach that we ensured that countries know the benefits, not only but also some of the ways they can engage men in eMTCT. Next slide, please. The second point that we found really important was to measure it, because we know now what they said, that what you don't measure doesn't get done, and there was a lot of talk about, discussion about which indicators we can include, because we another technical document that we developed in support of our countries was a regional monitoring framework. And we did not want to overburden countries with measuring, and so there was a lot of consideration put into which indicator for male involvement to include in the regional monitoring framework. And so we it might not be the best one, but we selected the percentage of syphilis seropositive pregnant women whose sexual partners are appropriately treated. And so that indicator is included in the country's reporting mechanisms, and you see the slide of the 2015 report that gives an overview of the countries, what the countries have reported. Important maybe to state that some countries do have efforts in place to engage men, but they might not have the mechanisms in place to document it. And so that's another implication, that once we want to measure male involvement, we need to know which indicators would be most suitable to reflect that, and also support countries to put in place the mechanisms to monitor that. And so monitoring of implementation, we noticed, was one of the important pillars of supporting countries to promote and to advance male engagement. Next slide, please. And so I'm quickly going to go through some country experiences, because as we and I think it would be very good maybe for our region to systematically document these experiences, because as several speakers said, documentation is an issue, and systematic documentation, so we can all learn and improve. I think Melanie already highlighted the Cuba experience, so I don't have to say much, only to say that over 95% of male partners of pregnant women are routinely tested for HIV and syphilis. For all the reasons that Melanie mentioned, Cuba has a very robust health system, services are free, and in their national strategy, they do have included encouragement of male involvement in antenatal care, and so they are managing to achieve very high coverage of male involvement. And as we know, Cuba became the first country to be validated for eMTCT. Next slide, please. The other country is Barbados, and Barbados has is achieving a coverage of over 80% of male sexual partners of pregnant women who test positive for syphilis who are also tested, and that is through the STI clinic. They have always had a very strong STI program with partner notification and partner tracing, and in the context of eMTCT, there is a really strong effort to ensure that pregnant women who test positive for syphilis, that their partners are found and also offered syphilis testing and treatment. Next slide, please. The third country, and as you see, these are very different ways the countries are elaborating on this effort. Suriname, which is my country for full disclosure, has again another experience with male engagement, where the program is being driven by the largest government hospital, where over 70% of women receive ANC and give birth in the coastal area. And it started as an initiative to encourage male partners to participate in antenatal care, initially through HIV, and expanded to syphilis, but it evolved into the provision of a comprehensive package of services for male partners, because the coordinators, the last time I spoke with them was about a month ago, they recognize that men have health needs too, and if you bring them to the center, it's a missed opportunity if you don't offer them services. And so some of the services they are offering are blood sugar, blood pressure, weight management related to NCDs, but definitely also HIV and syphilis testing and treatment as necessary. There's one challenge that they face, which is covering of the cost, because the services are offered in the antenatal clinic, unfortunately the payment system of the National Health Insurance does not allow the hospital to claim these costs, which again I think speaks to an element that we need to keep into account, that any engagement, the formula will have health systems implications. And so the costs are absorbed by the hospital, which is obviously for them not a good thing, but they value the benefits, and so they continue the program. Next slide, please. So in conclusion, male involvement in the Americas, it started off because of a public health rationale to achieve the very high, the very ambitious targets of eMTCT, but it evolved into also ensuring that the male population in some contexts that their health needs are met. It does require guidance and capacity building and monitoring. It is feasible. From the country experiences, we see that it is doable through several possible entry points, but we need to keep in mind that it does have health systems implications, and that we will need to help countries think through the health systems implications, definitely if we want to make these efforts sustainable. And that was my contribution. Thank you very much.
Hello, good afternoon. This is Avni. Could I ask you? Thank you. So I'm going to probably take a bit of a macro perspective in terms of what have we actually learned from what I call sort of the first generation of research and programming done with men or on male involvement in the context of, well, eMTCT for sure, but also some of the other sexual reproductive health issues. And what does this mean then for moving forward, particularly in terms of keeping the balance of engaging men, involving them, while at the same time making sure that the issues of women's rights, women's autonomy are also addressed at the same time in a balanced way. So next slide, please. Next slide. Okay. So why do we really, previous slide, I'm sorry. Adolf, could you move to the previous slide? Yes. Why do we need a critical stock take? Well, ICPD in Beijing, it's been 20 years that highlighted the importance of working with men. In the last 20 years, we've seen a lot of research and a lot of programming that's started to emerge in some SRH topics, particularly in the areas of maternal and child health, family planning, HIV, violence against women. And what we are at a stage where working with men and boys has become a mantra. So we've seen a lot of proliferation of academic research on masculinities. We have organizations that work on male engagement. And we also have a reflection of the need to work with men and boys in the SDGs. At the same time, and it's important to acknowledge that there is disquiet amongst feminist advocates on some of the focus and some of the approaches for engaging men. Important lessons have been learned, but there are some tensions and challenges, and I think it's important to be explicit about them so that we can then inform how this work can go forward in terms of the next generation of research and programming and development. Next slide, please. So this is going to be part of a paper. What I'm going to present is part of a paper that we're working on that looks at some of the conceptual frameworks that have informed the work with men and boys. We are also critically looking at the evidence on what works, what are the lessons learned, what are some of the tensions and challenges, and then use that to develop some ideas for guiding principles to inform the next generation of research and programming on male involvement. And the methods we've used are really looking at some key systematic reviews as well as systematic literature reviews published within the last 10 years that cover 3 specific areas. One is in the area of male involvement. The second is what I think Gary and Tim alluded to earlier, which is gender transformative programming with men. And then a body of evidence that specifically looks at men's own health outcomes, focusing on the SRH. And I'm not going to go into detail on the evidence for each of these 3, but just give you a snapshot of a few reviews that we have started looking at. Next. Next slide, please. So first of all, I just wanted to highlight that we tend to use these terms like men's health, male involvement, gender transformative programming in sort of this interchangeable way, and yet the conceptual frameworks, the body of evidence, what it looks at, the underlying theory of change for many of these interventions in each of these are quite distinct. The assumptions that go into designing these interventions are also quite distinct, and the specific subject matter that informs the development of some of these interventions is also quite distinct. A lot of the argument for focusing on men has come from this, that it is a gender equity issue, and yet it is a public health issue in its own right, and that should be the basis, because we're confusing here that sex-based differences which influence men's higher mortality and men's specific morbidities related to HIV or specific behaviors. So I think it's important to acknowledge that. Then you've got the male involvement literature, which often has this idea that we need to engage men as partners in support of women's health, whether it's in the context of maternal health, family planning, reproductive health more broadly, and PMTCT. And here the assumptions going into a lot of the design of interventions is that men are partners, they are gatekeepers, they are the decision makers, and therefore we need to encourage them to be involved in women's reproductive health and decisions. And then there is some of the interventions that are explicitly designed from a gender transformative programming, where there is an emphasis on changing harmful masculinities or dominant male norms, as well as addressing some of the power dynamics between men and women, largely at an individual or group level. Next slide, please. Next slide. Yeah. So we tried to categorize some of the reviews and the interventions based on these 3 categories. And so what do we know about male involvement interventions that looked at women's reproductive health outcomes? There is a Cochrane review of male involvement in PMTCT from 2012, which specifically looked at HIV uptake and PMTCT related behaviors. And based on the very rigorous criteria that Cochrane has, looking at risk of bias assessment, etc., they only found 1 randomized controlled trial from Tanzania that met the criteria for inclusion. And particularly what it showed was that there was negligible impact on uptake of PMTCT, and perhaps more importantly, which we can discuss later, 67% loss to follow-up. And the conclusions and the limitations that the study, the review highlighted are listed in the last column. Then there is a systematic review of male involvement interventions in maternal and newborn health, and this was undertaken as part of WHO's health promotion guidelines for maternal and newborn health, which had a specific PICO question around and recommendation around male involvement. And here, one of the issues that was found was that the range of male involvement activities varied. There was no clear definition or no clear understanding of what constituted male involvement. It could be anything from mass media campaigns to couples visits to just sending text messages to men to sort of working in groups with men to just workplace education. And again, there was not enough evidence to actually say which particular approach was more effective than others. And when they looked at the grade criteria, the evidence was graded as low to very low. However, the group did make a recommendation for male involvement with a number of caveats, which include the need to make sure that there was rigorous monitoring, rigorous research to make sure that this approach did not actually undermine women's rights and autonomy. And then there was another literature review on integrated gender interventions in reproductive maternal newborn child health, where they looked at uptake of family planning, couple communication, as well as gender attitudes. And this did not have any assessment of quality, but the study designs varied and the results were very mixed. In some cases, the focus was really on attitudinal change, but not on actual behavior change. And because we don't know the quality of the studies, we don't know how rigorous the study designs were. Can we go to the next slide, please? Next slide, yeah. And finally, I will highlight another one, which is a systematic review of gender transformative interventions for reducing risk of HIV and violence. And here there was an explicit focus on those studies that looked at gender transformative interventions with men or with men and women together. And they looked at sexual behaviors, violence perpetration, as well as things like condom use, etc. And again, the authors themselves, and again the results, some of them had very positive results. Some of them had results that improved gender attitudes, but had no statistically significant results on sexual behaviors. And the study designs, as the authors point out, were also quite variable, with weak designs pre and post with no comparison group. And there was no information given about intervention fidelity on what constituted gender transformative interventions and how rigorously and faithfully they were actually implemented to address the issues of power and norms. Next slide, please. So a quick analysis of the evidence. We've made a lot of progress, as the previous speakers have pointed out, in how male norms and role of men is critical for SRHR outcomes. We are making some progress on programming and evaluation of interventions with men, and it would be great to see some more rigorously designed studies that were presented earlier. I think the randomized control trials from Rwanda and the study from Brazil, it'd be good to see the outcomes of that and really have a robust body of evidence to move forward on. What we see is really that male involvement and gender transformative interventions are sometimes distinct, and we don't necessarily need to mix the two, because male involvement interventions don't always explicitly address gender equality. And the interventions for male involvement have mixed results. If you're looking at the 67% loss to follow up, it can be a poor study design, but it also may tell you something about selection bias and where women in with more supportive partners may want that to happen and should be encouraged to come back with their male partners and facilitate it. But there may be a significant proportion of women, particularly in abusive relationships, where we need to be careful and cautious about how we implement male interventions. And this was one of the conclusions in the randomized control trial in Tanzania, that a large number of women didn't come back because of fear of violence. Then the gender transformative interventions, there are largely small group interventions, and the reflection is explicitly on norms as well as on power relations, and they do change men's attitudes towards gender equality in a relatively short frame. So that's a great thing. The interventions, however, vary by their participants, the strategies, the structure, the goals, the theory of change, and again, sometimes it's hard to know what is working and what isn't. We also have other promising interventions which include both men and women at the community level that are promising and need to be looked at. Next slide. Next slide, please. And what we know from some of the interventions that have worked, the ones that explicitly foster critical reflections about power, about norms, and about relationships are some of the ones that tend to work, are more likely to work. They support the development of new skills in communication and conflict resolution, and they highlight both the benefits of and promote positive notions of masculinities. A majority of them in many of the reviews, even though they were billed as gender transformative interventions with men, some of them actually work with both men and women. And they also promote the larger involvement of community members. They have sort of combination sort of components where the small group interventions include also a component with working with media or having other sectors get involved. And those interventions that work are more likely to work are informed by a clear theory with very clear changes. Next slide. So what are the limitations of this body of evidence that we have? A lot of the evidence comes from high-income countries. We have fewer number of studies from low and middle-income countries studies, but that is increasing and that is changing. So we need to sort of build on that. There is a lack of clear operationalization of terms like male involvement and gender transformative, and so we don't actually know what we're comparing. Sometimes it's apples and oranges. Sometimes male involvement can mean exactly what Tim said earlier, paying for the bus fare, and then it's in the same basket as interventions that are actually changing power dynamics. So we need to be clear what it is that we're saying when we say male involvement or gender transformative interventions. The quality of evidence overall is weak, and a lot of the studies are underpowered with minimal controlling for confounders. And there's been a lot of emphasis on measuring attitudinal change, but the changes in behavior, particularly in a short period of time, have been less observed. And we know that attitude changes don't always result in behavior change. So I think we need to really emphasize that this is an important area of going forward from a research perspective. And a lot of the interventions, we don't have evidence on cost effectiveness. Next slide, please. I just wanted to maybe highlight some of the conceptual challenges that have happened in the first generation of programming on this work. And it really comes down to this whole idea, what do we mean by male involvement? And we assume that by working with men, we're addressing gender, when a lot of it can actually just be either accepting those gender norms as they are, reinforcing them, or it could mean that there is genuine effort to address the issues of power and norms and women's autonomy and rights in the whole package. But we don't know that because the studies are all mixed. Similarly, the understanding that if you're working on male norms and masculinities, you're actually changing some of the issues around power, privilege, and entitlement at an institutional level is something that needs to be also questioned, because it is a tension. If you're, for example, working on male norms with men in communities, but you're not changing how the sports institutions or the media institutions are reinforcing men to say, okay, you don't really need to accompany your wife, then you're not really changing gender inequality at that very structural level. And that's something that in the next generation of programming we need to think about it. Sometimes the work with men and on gender can actually inadvertently reinforce harmful masculinities and undermine women's rights and autonomy, and we need to be really careful about monitoring that and in the next generation of programming and research. And then it's a larger conceptual issue. We assume that working on male norms requires working only with men, or vice versa, that working on female norms requires only working with women. And yet what we know about gender norms is that those norms really occur at a community level and not necessarily appropriated to one one group or another. And so it's just something for us to really think about as we start thinking about the next area of work. And lastly, the impact on women's rights and autonomy and getting women's perspectives into those studies, into the evaluations and into the process evaluations is an important issue, because we actually don't know what women think of some of those male engagement interventions and how they've been affected either positively or negatively. Next slide, please. I wanted to actually just point out to the second bullet point on this slide, which is really the implementation of sometimes what I call gender blind male involvement policies and programs, and highlight that this has been a particular issue in the context of some of the PMTCT efforts in sub-Saharan Africa, where there are sort of blanket, in some of the countries, there are blanket targets put out for getting couples. And what you see in the end is that these are also contexts with very high levels of violence. And in the end, women don't come back, or women are sent back by healthcare providers because they've not come back with their partners for HIV testing. And I think we need to sort of think about some of those policy implications and how they are implemented in a context of very high levels of violence, particularly because at the same time that we are recommending partner testing, partner notification, male involvement, etc., we are also recommending that these same services, including antenatal care, identify women during pregnancy with violence. And we are very clear that you should not do identification of violence, intimate partner violence, when the male partner is present for ethical and safety reasons. So I think we'll have to balance some of these things that we need to address, both in the context of violence prevention as well as in the context of male involvement. And I just also wanted to say that there's some very problematic conceptual terms that are creeping up in some of the work on male involvement, notions around men's rights, male responsibility for protecting women, and from a gender equality perspective, some of those terms are also causing a lot of challenges for programs and how these things are being implemented. Next slide, please. Next slide. So just in terms of some preliminary thinking about how and where we should be thinking about the next generation of programming and research on male involvement, first is really for programs and research to be clear that working with men should abide by the basic principles of do no harm. And here it's very important to do some monitoring of how working with men does not actually undermine women's rights and autonomy or reinforce and reinvent some of the harmful ways of masculinities inadvertently, because they're not from the very outset conscious about some of those gender dynamics. The second one, and this is particularly for programming around gender equality, is really to make power and power reflection on the role of power and privilege and entitlement as the critical emphasis for some of the gender transformative work. And I would probably go out on a limb by saying that we need to think about the language here, whether male involvement and engagement of men needs to be reframed within the context of saying we need to actually focus on the end, which is gender equality, and address masculinities, male involvement, engagement of men and boys as one of the many ways that we can achieve gender equality, and not the only way. So really putting the goal first and then highlighting the different ways to reach there, including the male engagement piece as one of the ways. It is important to bridge the silos, and I think we need to talk about both harmful masculine as well as feminine norms. And coming from a field of violence against women, it's really, really important that we have health providers, communities talk about both those sets of norms that are equally harmful for both men and for women. Next slide, please. It is important to start sort of thinking about working on these issues at a structural level, and the HIV field has really been a pioneer in addressing some of the structural factors. But I think if you work only with men and boys at an individual or group level, and yet their sports, the media, the workplaces, the military, etc., all of these institutions are giving very contradictory messages to those same men who are in these groups and going back to those same settings, then I'm not sure how much of that work can be sustained over a longer period of time. So we do need to think of approaches that work at that level. And then lastly, I just wanted to pick on the last point, which is that moving forward from a research perspective, we really need to think about the quality of evidence that is there in being very explicit about the terminology, the operational definitions, the theories of change that underline whether it's male involvement, gender transformative programming, being sure that the research is increasingly measuring changes over time, because we sort of have these very time-limited interventions and then we don't know what happens afterwards. And then really thinking about what outcome measures we are measuring in some of the research, particularly focusing on behavioral outcomes and not just attitudinal ones. So I will end here and maybe just end with some 3 questions for me that have plagued me in thinking of some of this work that has happened. First is whether we have a coherent and consistent understanding across a wide range of stakeholders on what we mean when we say male involvement and the operational definition, and I think we all have slightly differing understanding of that. The second thing that's plagued me is that are we actually monitoring the harmful effects, and we need to think about that. And the third one is really the research and the evidence body, we need to think about how to strengthen that. Thank you.
Thank you, Avni. This is Stephen Nurse-Finley from the WHO headquarters in Geneva. I'd like to thank all of the panelists for their interventions, and I'd also like to thank all of the colleagues who have submitted questions today. Given that we are running a little bit out of time, what we will do at this point is we will say to all of the participants, we have recorded your questions, and we will ask the panelists to please answer those questions in writing, and we will send you a Word document with your questions and their responses, along with a link to the recording of this webinar within a few days, along with a confirmatory email. We will also post the webinar recording within the HRP video library. The web address isn't on the screen at the moment, and you will be able to access the entire recording of this webinar along with all of the slides. So at this point, if I can just ask all of the panelists, beginning with Manjula, to just give 20 seconds of your final thoughts of this particular webinar, and then after Manjula, Gary, Tim, Melanie, Sonia, and Avni have had 10 to 20 seconds, I will ask James to please close the webinar. So Manjula, your final thoughts, please.
Thanks very much, Stephen. Firstly, I wanted to thank everyone because it's actually been really interesting. And I think, we conceived of these SRH-HIV linkages webinars not simply to state the obvious, but to challenge ourselves to do better and to do things differently. Because in this particular topic of eMTCT, of HIV and syphilis, the issue of men engagement is really, it's problematic. It's been a barrier. How do we engage men? What does it mean? And it's really something I feel we're going to need to address if we're, as a global community, we are to reach the targets that are now being set and moving towards. So I wanted to thank everybody and look forward to further discussions and further webinars. Thank you.
Thank you. Gary, do you have any final thoughts you would like to share?
Sure. Just one, it was very rich to get to hear the varied experiences. I really appreciated Avni's reflections at the end. And if I look as well at terms of where I think the field needs to go, one, I think increased integration, that is across the health sector work that we're doing, and I think keeping the focus on power dynamics, and not only the absence and the reduction of violence, but also promoting gender equality in terms of caregiving, who does caregiving beyond. And I think looking at that Venn diagram that finds the overlap between men, women, the intersectionalities of sexual orientation, and also what this means in terms of the future caregiving and engagement of men and women in the care of children. So I think if there's any positive movement, and there is a lot, it's how do we step out of those silos, both public health, but also I think at a broader sense of power and very much thinking about gender equality, not just this is men engagement over here and this is the work with women over here. So I'm encouraged to see where it's going that way, and I'm thrilled to participate in future conversations about it.
Thank you, Gary. Tim, your final thought.
Thank you, everyone. This was a really rich conversation, and really exciting to see a lot of things and work that I wasn't aware of taking place. So yeah, I think we are in a stronger place, definitely, in terms of the evidence, in terms of the programs and the examples that have been shared. What I would say is, I think all of everyone's reflections points to the fact that whilst we do have some understanding of what works and what doesn't work, and we certainly have a clear understanding of critical tensions, we definitely need to understand more. There is a need for a greater focus on programmatic implementation, on implementation science, on research around what works and what doesn't, looking at the effective models globally that can be used to integrate men into this work, and also picking up points that myself, Gary and Avni and others have said around this work for men's own benefit as well, seeing that within the broader gender equality framework. But I would just say, I think a final thought is I think it's important that we do hold ourselves accountable for what we understand and think about as evidence. There's a lot of programmatic experiences out there, and I guess I do hope that as we look at our standards of research, that we don't just think about randomized control trials and other quasi-experimental and important models, but we do also, given that this is about changing social norms and societal approaches, that there's a whole plethora and decades of experience that isn't, in Cochrane reviews, but is critical to our understanding of how communities and nations change these norms of men and women for the better. So I hope that we embrace those as well as we think about the evidence. Thank you.
Thank you, Tim. Melanie, your final thoughts.
Thank you, Stephen, and thank you for organizing this webinar. It's been quite a pleasure to be part of it. I would just like to say in closing that, at least at the WHO level, as part of the eMTCT process, we are continuing to follow the activities of male engagement among countries that are applying for validation. Specifically, as Dr. Cafe mentioned, we do evaluate the partner notification strategies, and when data is available, we do look at the % of partners that are brought to treatment. But it does leave open the opportunity to prevent cases among women who are originally diagnosed as negative or tested negative at their first prenatal visit. So there are many opportunities for further male engagement, even among countries that have achieved validation or elimination of mother-to-child transmission. There's still opportunities for male engagement, even among those countries. And so even the best program still has ways to go or things to achieve when it comes to male involvement. Thank you.
Thank you, Melanie. Sonia, your final thoughts, please.
Yes, thank you, and also really pleasure to be part of this and to listen to all the different perspectives that really, I think we are all on the same page, really coming at the same point from different angles, and I think that would be my main point, that I see opportunities here for us to maximize the efforts and the learning, because this is really a learning process that if we place it in the context of eMTCT, goes at a very high pace because countries want to reach the eMTCT targets. And so I see opportunities to maximize our individual efforts in terms of collaboration and putting together maybe our efforts to ensure that we can generate lessons learned as early as possible and disseminate those, because countries are implementing as we speak, and this is a complex issue. No, it's not easy, but it is something that is critical to the eMTCT efforts globally and on country level. Thank you again, and I look forward to continue collaborating with all of you.
Thank you, Sonia. And Avni, your final thoughts, please.
the new research that's going on. Hi. Hello?
Please go ahead.
Oh, no, just to say thank you very much. It's been a very rich discussion, and it's been very interesting to learn about some of the work that's going on, and really I'm excited to see what comes out of some of the research, the new research that was presented earlier. Thanks.
Thank you, Avni. James, would you like to close the session? And thank you everyone again for your participation.
Yeah, thank you very much. Mine, I think, is to thank the participants, and also particularly for those who posted the very insightful questions. We really do sincerely apologize that we were not able to discuss the questions, and we promise to write the answers, and you can be able to see them on the webinar. And probably in future we'll really address the issue of time so that we're able to address your questions. Also to thank all the panelists for their inputs. I think it has been a very rich discussion, and the various partners, IBP partners and other stakeholders who joined today's webinar. And finally, in closing, to say that it is good that we are at this place where we are seeing that male engagement is feasible and is indeed desirable from a lot of the evidence that we have had. And just the realization that probably we need to sell this better to some of the policy makers, and the highlight that it is important to monitor it and also to consider other aspects from a broader perspectives, and particularly the issue that has been brought up about thinking about health systems, considerations, and costs. So we thank you very much. You will see the website. We have posted it there, where we are going to post the webinar. And if you would like to follow our department on Twitter, we have our Twitter handle there, and also please do visit our website. So again, thank you very much, and thank you Stephen and Ados for all the work you have put into organizing this seminar. Thank you, and bye-bye.